project will be on Graves' disease, understanding the causes, symptoms, diagnosis. Some fast facts about Graves' disease. Graves' disease is the #1 cause of hyperthyroidism. The peak age of diagnosis is between 40 and 60. Graves' disease is 7 to 8 times more likely to affect women than men, and Graves' disease affects 3% of the total population. Graves' disease is an autoimmune disorder characterized by the overproduction of thyroid hormones due to stimulating antibodies. It causes enlargement of the thyroid gland and increased thyroid activity. The exact cause is unknown, but is believed to be a combination of genetic and environmental factors. Pathophysiology of Graves' disease. Graves' disease is the presentation of exophthalmos, which is due to edema of the extraocular muscles and increased fatty acid behind the eyes. Exophthalmos often causes blurred vision or double vision and tiring of the eyes due to the pressure on the optic nerve. Excessive tearing and bloodshot appearance of the eyes is apparent with Graves' disease. Eyelid retraction or lag is the movement of the eyelid that is delayed when the eyes move downward. Globe or eyeball lag is when the upper eyelid pulls back faster than the eyeball when the client gazes upward. Pretibial myxedema appears as a dry, waxy swelling in the front surfaces of the lower legs that resembles benign tumors, and this manifestation occurs only with Graves' disease. Thyroid eye disease, or TED, is an autoimmune disease in which eye muscles and fatty tissue behind the eye becomes inflamed. This inflammation can push the eyes forward or cause the eye or eyelids to become red and swollen. TED is also known as Graves' orbitopathy or Graves' eye disease. About a quarter of the patients with Graves' disease will develop TED before, during, or after the diagnosis of thyroid disorder. In rare cases, TED can cause blindness and pressure on the nerve in the back of the eye, or ulcers that form on the front of the eye. Smokers are 8 to 10 times more likely to develop TED. Symptoms of TED include bags under the eyes, difficulty moving the eyes, low tolerance for bright lights, changes of the eye's appearance, usually staring or bulging, pain in or behind the eye, especially when looking up, down, or sideways, and swelling or fullness in one or both upper eyelids. Treatment options for TED include decompression surgery, which removes bone and soft tissue from behind the eye to create more space, eye muscle surgery, which corrects severe double vision, or eyelid surgery to improve the appearance and function of the eyelids. Blood TSH level is often decreased in the presence of Graves' disease and can be elevated in secondary and tertiary hyperthyroidism. Free T4 index, T4 total, and T3 is elevated in the presence of Graves' disease. Thyroid-stimulating immunoglobulins are elevated in Graves' disease and normal in other types of hyperthyroidism. Thyrotropin receptor antibody elevations are most indicative of Graves' disease. Diagnostic procedures for Graves' disease includes ultrasound, electrocardiogram, and thyroid scan. An ultrasound is used to produce images of the thyroid gland and surrounding tissues. An electrocardiogram is used to evaluate the effects of excess thyroid hormone on the heart, which can manifest as tachycardia and dysrhythmias. ECG changes include atrial fibrillation and changes in P and T waveforms. A thyroid scan is a nuclear medicine test that clarifies the size and function of the thyroid gland. The uptake of the radioactive isotope administered orally 24 hours prior to the test is measured. An elevated uptake is indicative of hyperthyroidism. Although hyperthyroidism is the most noticeable symptom of Graves' disease, it frequently coexists with other symptoms. The most reported manifestations of Graves' disease are also the symptoms of hyperthyroidism. As a refresher, the common signs and symptoms of hyperthyroidism include nervousness, irritability, hyperactivity, emotional lability, decreased attention span, changes in mental or emotional status, weakness, easily fatigued, exercise intolerance, muscle weakness, heat intolerance, weight loss that usually accompanies an increase in appetite, frequent stools and diarrhea, insomnia and interrupted sleep, warm, sweaty, flushed skin with a velvety smooth texture, thinning of the hair that develops a fine, soft, silky texture, tremors, hyperkinesia, and hyperreflexia. Symptoms of the eye include swollen eyes or exophthalmos, eyes that are gritty or irritated, tears that are excessive or dry eyes, eyes that are red or inflamed, blurry vision or double vision, light sensitivity, eyelid swollenness or retraction, and difficulty moving the eyes or weakness of the eye muscles. Medications used to treat Graves' disease include thionamides, beta-adrenergic blockers, and iodine solutions. Methimazole and propylthiouracil inhibit the production of thyroid hormone. They are used primarily to treat Graves' disease as an adjunct to radioactive iodine therapy, to decrease hormone levels in preparation for surgery, and to treat thyrotoxicosis. Beta-adrenergic blockers such as propranolol, atenolol, and metoprolol treat sympathetic nervous system effects such as tachycardia and palpitations. These medications counteract the effects of increased thyroid hormone but do not alter the level of the hormones. Iodine solution such as Lugol solution is a non-radioactive 5% elemental iodine and 10% potassium iodine that inhibits the release of thyroid hormone. These medications are for short-term use only and are usually taken 10 days before surgery. Radioactive iodine is taken up by the thyroid and destroys some of the hormone-producing cells. One dose can be sufficient, but a second or third dose might be needed. The degree of thyroid destruction varies and can require a lifelong thyroid replacement. A thyroidectomy is the surgical removal of part or all of the thyroid gland. A subtotal thyroidectomy can be performed to treat hyperthyroidism when medication therapy fails or radioactive therapy is contraindicated. After a subtotal thyroidectomy, the remaining thyroid tissue usually supplies enough thyroid hormone to maintain normal function. With a total thyroidectomy, the patient will need lifelong replacement therapy. The patient will need to also follow a high-protein, high-carbohydrate diet prior to surgery. Nursing care for the patient following a subtotal or total thyroidectomy. Keep the client in a semi-Fowler's position, support the head and neck with pillows or sandbags, and avoid neck extension. Assist with deep breathing exercises every 30 to 60 minutes. Provide oral and tracheal suction as needed. Check the surgical dressing and the back of the neck for excess bleeding. Respiratory distress can occur from compression of the trachea due to hemorrhage, which is most likely to occur within the first 24 hours. Respiratory distress can also occur due to the edema. Check for laryngeal nerve damage by asking the client to speak as soon as they awaken from anesthesia and every 2 hours thereafter. Administer pain medications as ordered for discomfort, and check for indications of hypocalcemia, which can result from parathyroid damage. Eye care for patients with exophthalmos. Eye shades for patients with photosensitivity, eye drops to keep the eye moist, cover with clean gauze, usually at bedtime, to promote sleep, raise the head of the bed to relieve eye swelling, question and clarify medication orders for aspirin, and avoid the use of aspirin as this can increase free thyroid hormone in the system. The diet should be high in calories and high in protein. Nursing management of hyperthyroidism. Provide a cool environment. Minimize stress by providing privacy and placing the patient in a private room. Teach the patient to avoid stimulants such as coffee, sweets, tea, soft drinks, energy bars, and cigarette smoking. Watch out for signs of agranulocytosis, such as a sudden onset of fever or sore throat when a patient has medications such as PTU or methimazole, and monitor for other unusual manifestations such as allergic reactions to drugs. Complications related to Graves' disease, hyperthyroidism, and post-thyroidectomy surgery. Hemorrhage due to loosened surgical tie, excessive coughing, movement can occur at the incision or in the tissues, leading to respiratory distress. Thyroid crisis, or storm, results from a sudden surge of large amounts of thyroid hormone in the bloodstream, causing an even greater increase in body metabolism. This is a medical emergency with a high mortality rate. Precipitating factors for thyroid crisis include uncontrolled hyperthyroidism, infection, trauma, emotional stress, diabetic ketoacidosis, and digitalis toxicity. The priority nursing action is to maintain a patent airway. Airway obstruction can be caused by hemorrhage, tracheal collapse, tracheal mucus accumulation, laryngeal edema, and vocal cord paralysis. These complications can lead to respiratory obstruction with sudden stridor and restlessness. Hypocalcemia and tetany can be caused by damage to the parathyroid gland.